So, hello and good evening and welcome to the Crown Mitre Hotel. My name's Jackie Robinson. I'm here as an independent chair for your public meeting this evening. I am completely independent. I don't work for the NHS. I work for the Consultation Institute, and we are fielded out across the patch, across the country, to enable public consultations to take place effectively. What I can tell you is I've worked across health and social care for over 35 years, so I do understand a lot of the challenges and changes, and I've run hundreds of public consultations. And what I find is, I think if we're all able to be respectful to each other, we've clearly got questions we want to hear, we've clearly got questions we want to answer. So the format of this evening will be a very short presentation from a colleague from the NHS, and then it will be over to you, because this is your public meeting. And it will be a question and answer session. It will be through a show of hands, and I can promise you I will work through the room for the whole evening, but I would ask you to work with me, please, and have one voice at a time. It makes it incredibly difficult when people start to try and shout over somebody else to make their voice heard. So if we could do that, that would be absolutely great, because there's an awful lot of people in this room this evening. Just in terms of some housekeeping, clearly we've got our signer here this evening. Can I just ask, is there anybody who does need a signer this evening? Okay, we're going to do two things. Oh, so we're fine. We just needed to check that we've got somebody who needs to see that. That's fine. So you're happy to continue? This lady in the front. We just want to make sure she's over your side. That's great. Okay, I understand there's no fire alarm plan for this evening, but clearly if there is a fire alarm, it's for real. Please go through the fire exits and convene at the front of the building. Okay. If you are using a hearing aid, if you could turn your hearing aid to the T-coil position, please, to make things easy for you. Mobiles, love them or loathe them. I think we've all got them, haven't we? If we could put them on silent for the duration of the meeting, that would be great. There's nothing worse than a burst of Bohemian Rhapsody when somebody's trying to explain or ask a question. We are using microphones throughout the evening, and this session is being recorded. Apparently it's being uploaded onto a website for colleagues and members of the public who couldn't attend. So there's a couple of reasons. One, when you ask a question, could you please use the microphone? Secondly, it would be really helpful if you could let us know what your name is or if you represent an organisation. However, because this is being uploaded onto the internet, you may choose not to use your name, and that's your choice, so that's fine. Just so you know, really, when you take the mic, there goes the first phone. Okay. And then finally, I'm just going to introduce you to our panel, who I've never met before, so I hope I get your names right. I did fluff last night and missed somebody off. So we're starting off at the very far end with Michael Smiley, who's the Director of Strategy and Support Services, and also an executive lead for Cumbria Partnership NHS Foundation Trust. Next to Michael is Stephen Charles, who's the Chief Executive Officer of NHS Cumbria CCJ. Next to Stephen's Matt House, who's from North West Ambulance Service. Next to Matt is Helen Ray, who's the Deputy Chief Executive and Executive Chief Operating Officer at North Cumbria University Hospital NHS Trust. And finally, next to me is Moya Cushlow, who's the Interim Director of Nursing and Midwifery, North Cumbria University Hospital Trust. Was that correct? Oh, so it's the director. See, told you I'd fluff something, but hey ho, we'll get there for the night. So let's start off then, if we may, with our presentation, and then I'll come over to you one by one and take your questions, ladies and gentlemen. Thank you very much.
Thank you. I'm going to take us through some slides. Hopefully you can all hear me, and if you can't hear me or if it's not particularly clear, I'm comfortable for you to just point it out, and I'll try and clarify the slides. This consultation is being undertaken by NHS Cumbria CCG. The consultation is being undertaken by them because they have the legal responsibility for leading local consultations. But however, the proposals have been brought together by working closely across a number of local organisations in the NHS. and particularly working closely with the success regime, which is something that we've been working within for the past year or so. There are 3 success regime areas in the country for the areas with the highest level of challenge in delivering healthcare sustainably. Now, the outcome of public consultation is really important, and is an important factor in how we make decisions for the future. So your views in the consultation process will be considered alongside the other clinical, financial, practical considerations that have to be taken into account in arriving at final decisions. This process of consultation is an opportunity for as many people from the community as possible to register what they think about the proposals put together and for their views to be taken into account in the decision-making process, which takes place after the end of consultation, which finishes on the 19th of December. There are no decisions made, so the consultation takes place, and it's only after then that all of the responses are considered and analysed, and decisions are made after that process. So,
ladies and gentlemen, can we please allow presenters to finish? We will do a question and answers. If you can we be some respect, please, sir? Okay. We're all going to have an opportunity to speak. Can we work through this together, please? Thank you.
So we're here to obviously listen to what you have to say. The responses will be analysed independently. The decisions were made and timetable to be made in spring of 2017. Now, public consultation isn't a vote or a veto, but it is an opportunity for people to tell us exactly what they think about the proposals and for us to take that into account in any decisions that are made. So why have we had to bring proposals together in this consultation? Well, we've got some really big challenges, some of which are well known. We know that overall the population health here could be better, and part of that is about how our health services could be improved. We have real difficulty attracting all of the staff we need, particularly doctors, nurses, but other key professionals as well. And not just attracting them, but retaining them here. We know that too many people find themselves admitted to hospital with longer stays than we'd like them to have. And we think some of that is avoidable through better services. We're also, because of some of those above reasons, overspent. We receive an allocation, and we're spending more than that allocation at the present time. And a number of our services have not met the standards that we're expected to meet, particularly from the CQC, where standards are tested. And those are some of the really big challenges that we face behind the proposals that we're putting forward in this consultation. Another key factor, I think, as somebody who's lived and worked here for a long time, I'm well aware that uncertainty doesn't help either. And some of the issues we're grappling with, some of the issues that we've had to bring to yourselves in consultation aren't new issues. They have been issues for a long time. And we are trying to, where we can, put forward a future that's less uncertain and more certain. So we're trying to tackle those issues that if we don't, will actually potentially continue uncertainty or indeed make our challenges bigger in future. So this process is about trying to get as many people as possible giving us their views to help us make those big decisions. We have developed a vision that we think can last and give us a sense of purpose here that can really help our services thrive in future. We think integration is a major issue for us in this place where our communities are often sparse. We think integrating services is a real benefit here. We know that we have remote and rural communities, dispersed communities, and we think integrated care is an opportunity for us to be a centre of excellence for the future, which is not where we start from now in terms of the challenges we face. One of the key, therefore, tenets of our overall plan, including the issues that we're proposing through the consultation, is that we will develop our services into what we're calling integrated care community-based services. So we're trying to join up care around communities, around populations, So depending on the area in particular, working with populations, perhaps up to 70,000 people altogether, where we can join up care for that population. We're trying to work and do that within and across the NHS, all of the partners, with social care and those really important community organisations, the voluntary sector, for example, that exist in our communities. We're trying to do that so that people can be independent, receive care where they live, if possible, or close to their home, if that's not possible, and that we care for people with good outcomes so that when people need a hospital intervention or need escalated care, the services are there for them. At the moment, we feel that the So we're trying to rebalance services so that we can care for people as much as possible whilst they're healthy and well, and keep them that way and care for them in settings closer to their home. Clearly, what we're trying to do is to make better use of the hospitals where we can, and do that through using technology and also by adopting new ways of supporting people in future. So we think by working in a more integrated way, our services can be overall more safe and deliver higher quality. We think that it can be more clinically sustainable, and our clinicians have helped us with these proposals with a view to them being more clinically sustainable, and we think fundamentally overall it can be more financially sustainable. So I'm going to go through for clarity what we are proposing in the consultation. First of all, with regard to children's services, we identified through a large piece of work a number of options that we could consider. And on balance, we've arrived at a preferred option, which is the one highlighted on the screen, which is where we intend to continue providing inpatient services at both the local hospital sites, acute hospital sites in the county. However, at West Cumberland Hospital, low risk and short stay assessment will be provided, and at Carlisle, all the other services provided, including the short stay service as well. So with regard to children's services, still providing services at both hospitals, but with a stratification, if you like, of what's provided at each.
What does that mean, stratification? What does that mean?
It means where there is individuals with a higher level of risk, they'd be treated at Carlisle rather than at West Cumberland Hospital.
Well, say that.
For maternity services, we've looked at a number of options. Clearly, all of the options have a different level of impact. In arriving at a preferred option, on balance, the proposal is to have a midwife-led unit at West Cumberland Hospital, and for there to be daytime consultant cover provided alongside that midwife-led unit. With regard,
Can we please hold the questions till the question and answer session, please, and just come through the presentation? Just a slight bit of order would be helpful. Thank you, everybody.
With regard to community hospitals, we've identified 4 key options, and we've arrived at a preferred option, which is to consolidate community hospital beds on 6 sites. We feel that there is a very strong potential and desire to maintain services on all the sites by providing ambulatory care for people who can attend clinics, for example, or diagnostic services, but only on 6 sites for there to be overnight beds. Now, those 3 sites that wouldn't have the beds have been identified in the preferred option as being Alston, Wigton and Maryport. With regard to taking forward these plans, we think there is potential for us to work on, with communities, work on alternative preferred options possibly, and we've been facilitating some work with communities to try and do that during the consultation period. The main drivers behind those options were a mixture of 4 issues. The first is that the different size of the units. We know that some of our units are quite small, compared to benchmarks across the country, very small. We know that we try to provide staffing for the units where we have a qualified member of staff for every 8 patients. But actually that means that sometimes that qualified member of staff is the only qualified member of staff available. And that's not very resilient if that member of staff is called to do something different or isn't available. So we're trying to provide, in the consolidated preferred option, trying to provide services with at least 16 beds on each of the sites so that we have 2 qualified members of staff available at any time. We know that geographically we would like to provide these services across West, North and East Cumbria. So we've selected the 6 sites to try and maintain a geographic coverage. And with regard to practical issues, we've also had to look at the condition of the sites as they currently are and whether or not they can indeed be fit for the future in a way that's sustainable. So those are the issues driving some of the background behind those proposals. With regard to emergency acute care, we've looked at different options and we've identified that we think we can, only through quite a significant degree of development of the workforce, maintain A&E services at both of the hospitals across Whitehaven and Carlisle. And that's reliant on quite an innovative model of developing different types of skills around doctors so that we can have nurse practitioners and things like that in future supporting the service be sustainable. We've also looked at the future of stroke services across the patch. And increasingly, what evidence shows is that where people get a very quick intensive service immediately after having a stroke, their outcomes are much better. So in line with many other parts of the UK, we feel like we need to develop a hyper-acute stroke service. And looking at the potential for that, we think that would be provided at Carlisle. And that would mean people attending Carlisle once they've had a stroke for the appropriate diagnostic tests and initial treatment. Alongside the hyperacute stroke service, we would want to maintain and plan to maintain all of the post-acute rehab care as locally as possible. Now, our financial position, as mentioned earlier, is one of the key challenges we face. We know we're overspending at the minute. We know that if we don't do anything, the overspend will increase, and we think we can become more efficient.
Please, ladies and gentlemen, can we please wait for the question and answer session so we can move this session on? Well, we've not allowed for any questions yet because we can't get through the presentation.
We know we can be more efficient and have identified opportunities to be so. And we know that we can, as I've mentioned in some of the options, find new ways of working. But the clinical changes proposed in themselves don't deliver a high degree of financial benefit. It's the other issues on this list that give us some savings. And finally, the last slide, before we open for questions, just wanted to say, because this is an area that there's been a large degree of conjecture about for many years, we do see a very positive future for West Cumberland Hospital in particular. Clearly, as a new hospital, we see some opportunities for acute surgery returning there. Currently, we think there are too many people from the west of the county having surgery elsewhere, and we think with the new hospital we can bring that back, which is hopefully better for local people in West Cumbria. And that's the same for some trauma care too. We know that West Cumberland Hospital has the potential to be a place for high-quality planned surgery. So there is an opportunity for us all to benefit from that facility across Cumbria. And we're planning a new major diagnostic suite there as well to enhance the outpatient services that are provided. So we think overall there will be more people treated at the West Cumberland Hospital site than has been the case in the past. So I'll end the presentation now, thank you.
Okay. Now it's the opportunity to ask questions. I will work my way around the room, but clearly there are a lot of people who've got a lot of things to say, which is absolutely fine. But can I please ask for people not to shout across the room? It won't help you ask your questions, and it won't help the panel answer them. But we will work through them this evening. Trust me, I am here to work independently on behalf of you, the public, to ask you questions. So can we start? Shall we start at this gentleman at the back first, and then we'll work our way through, and I'll come back to you.
Could you put the slide up that gave the savings? That's the one. Now, I'm not going to accuse the people on the top table of telling lies, but there are some things that they're not telling you. And by omission, they're leading you up the garden path. PFI in Carlisle is currently paying £24 million a year. A year. And it's going up every single year. Interserve, and this is one of the questions, I suppose. What did the panel do about Interserve? Interserve was one of the two companies that built the hospital. And in 2012, they sold their share of the hospital for £90 million. That just happens to be £15 million more than the hospital cost to build. So there is plenty of money in the health service. It's just in the wrong bloody hands. Interserve sold
Is that your question, sir? Sorry, is that your question?
No.
Well, you've asked the question.
I want to tell people about PFI.
Can we keep... We will.
They want to...
Do you want your question answered? Do you want... You can. I'm fine. Can I check the question? That's all I'm trying to do. Okay. Let's just
Interserve,
have a bit of order. Carry on, and we've got the question to cover.
Interserve sold its shares to Dalmore Investment Fund Trust. Dalmore is an offshore investment fund. So the £24 million a year that you're paying is going to Dalmore, and they're not even paying bloody tax on it. They're not even paying tax. It's an absolute disgrace. They extended the contract by another 5 years so that Dalmore could get more money. And at the end of 35 years, at £24 a year, 24 million a year, index-linked to inflation, you will be paying, you and me, more than £1,000 million, more than £1 billion for that hospital. Finally.
Well, how did you let that happen?
I didn't let it happen. Yeah, I did let it happen. But it's the government that let it happen. And the government told people, well, there you go. Yeah, it certainly was. And we have another problem. The fire service visited the hospital 2 years ago, and they failed the fire test. They served a notice on the hospital and went back a month later. They had to serve another fire notice on them and told them that if they didn't get the hospital fixed, it would be closed. Now then, we found out by asking questions under freedom of information, because it's not coming from anybody on the top table, that they built the hospital that we all use, and it doesn't have a firewall in it. Not one firewall. And it's illegal. And it's going to cost £14 million to fix. Now, I'm suggesting that the top table make a pretty strong recommendation, just like the Scottish Government did when they found schools that had been built under PFI had been wrongly built and were dangerous. They cancelled the PFI contracts with the PFI companies.
Okay, I'm gonna stop you there for a moment. I'll come to you in a minute. I'm going to stop you there. Two things first, panel. I think, can somebody give some feedback in terms of PFI? Because clearly that's an issue. I'm not really clear, other than that, what was your key question? And I can come back to you, but I need to make sure we give other people the opportunity. Is there somebody who's prepared to take that?
Okay, thank you very much. Yes, we do have a PFI contract. This gentleman's absolutely right to say that. I can stand up, of course, yeah, that's helpful. For estates and facilities, so you started, I think, by talking about the cost associated with that. So there will always, for estates and facilities, whether it's PFI or whether it's run through the local hospitals, be a cost attached to maintain and develop and forward view your hospital services. So the cost associated with that, the cost associated with that will always exist because we have to run a sensible estates and facilities programme. There is a very clear contract in place with our PFI contract provider to manage that.
Can we have a bit of order, please? Let people answer the question. Thank you.
So like any contract, whether it's a PFI contract or whether it's a different type of contract, we manage that robustly with our contract provider. We also receive a subsidy as an organisation to help us with that. We get that centrally funded from the government every single year through the PFI. Sorry?
And the government takes it back from the health service.
I can't really comment on government policy.
Well, but they do, you know they do.
I won't comment on government policy because that's not really the purpose of the consultation. This is about the future service provision. I absolutely understand that there will be a significant proportion of people in this room today who feel that the public policy is a contributory factor to where we have presented. And that is your opinion, but it is not the purpose of this public consultation. This public consultation meeting is about hearing the general public's views on those options that have been presented in the presentation. If we try to fix central government policy here, we probably wouldn't get out in the next week, would we, in terms of trying to think that through. But that is not the purpose of this public meeting. It is about the consultation and the options that have been presented to you today.
What if we don't want any of the options? None of the above.
So if you do not want that, if you don't want PFI, if you don't want any of the options, that is absolutely within your gift to put that forward as your opinion. And as Michael said earlier when he presented, that will all be considered within the independent review of the outputs of these public consultation meetings.
Please put that in minutes.
Certainly. We're going to move on to another question, please, if you don't mind. May we come to you in the front? I know you've waited, and then the man in the green, and then the man next to you, and then we'll come here. I'll work my way round, honestly.
Thank you very much, Jackie. For those of you who don't know me, I'm Rebecca Hanson, and I'm an elected councillor based in Cockermouth. I came to one of these consultations a few weeks ago, and I asked some simple questions, was horrified by the answers I got, and have done an awful lot of work to research what the implications of the proposed changes will be. And I've written 2 reports. One is on the issue of obstetric transfers, which showed that there was no precedent for this. And the other was on the risk associated with women travelling long distances in labour, which they will need to. And the risks are very substantial. Thank you. Most of the members of the panel have already seen these reports, so they've had time to consider them, and thank you for the responses that I've had from them so far. But my question tonight is, that we know that the birth outcomes for women who live 1 to 2 hours travel from obstetric care, that's emergency cesarean section, are horrific, both by the medical logic and by the international research which considers places where this happened, which is entirely hyper-rural areas at the minute. So when the changes go through, we will have 700 women a year who are under the care of Carlisle Hospital for their obstetric care who are in this situation. So the international research shows that that will lead to 7 unnecessary neonatal deaths in the next 5 years, 80 babies needing special care that would not have otherwise needed special care because of the distance parents are travelling, over 1,000 extra days of special care being needed that would not have otherwise been needed, 75 babies being born out of hospital by accident, and thousands of women having very, very stressful birth experience. So those that don't show up in the data are likely to have problems staying in labour over a long and twisty journey. They're likely to need to be induced when they get to hospital rather than having a straightforward birth. So what are the plans for Carlisle Hospital to scale up its maternity resources, not just to cope with the numbers of women coming in, but also to cope with the extra complexity that those women will have? That's my question.
Thank you, Rebecca. I think that's a really important point, and in actual fact, I've been with a group of midwives today looking at the options for maternity services and looking what the implications for that are. And it's absolutely clear that depending upon the outcome of the consultation and depending upon the choices that are made as a result of that consultation, there is some work that we will have to do to manage that transition. And that's about making sure that all of our midwives have the same skills, whether they work in Carlisle, whether they work in Whitehaven, making sure that we have midwives and nurses who've got trained skills in neonatal and paediatric care. And it's really important that our priority is around safe care for women and their families and the babies that they deliver. And I think it's really important that we work through that. The challenge that we've got now is how we manage that transition. And I'm pleased to say that the meeting that I've had today with the midwives, we've started to do that. There are things that we absolutely must do around our workforce to make sure that we've got the skills that are there to make this a safe maternity service. As it is now, a safe maternity service.
Can I come to you with a question in a moment so you can raise your question? I'd like to come to this gentleman in the green, please. He's waited patiently. Thank you very much, sir.
Thank you. My name's Brent Kennedy. I've been campaigning against the closure of half the beds in the care homes in Cumbria. Because that's obviously going to have a knock-on effect on the NHS. I think if this were really a genuine consultation, the fact that this lady has just raised that women and babies are going to die would be sufficient for you to withdraw all of these proposals. But in fact, this misnamed success regime and the STPs that work parallel that are being imposed in 44 areas all around the country are simply mouthpieces for a Tory government trying to destroy the NHS through cuts, privatisation and outsourcing. And I think that the options that you've presented us with here are the choice between death by drowning and death by strangulation, and we reject them all.
Do you have a question? Do you have a question?
Yes. I'd therefore like to make 3 brief proposals here. And they're proposals, I don't for a moment think that you're going to listen or act on them, but I think that the people present here who are serious about defending the NHS probably will. First of all, I think we should make it clear through the media tonight that we reject all the success regime's attacks on our NHS services. Secondly, I think we should call on Cumbria County Council to use its position to veto the parallel STP attacks on services and to withdraw its plan to halve the number of care home beds. And thirdly, we are going to fight this, and we're not going to fight it because Cumbria is supposed to be a special case, which it isn't, because we're going to fight this nationally. Users, campaign groups, political groups, trade unions. We're going to have a national demonstration in London in March, and I would ask everybody here to mobilise for it, because this is crunch time. This is make or break for the NHS itself.
Thank you. Can we come to the gentleman in the blue, please? Thank you, Fanny. Thank you. I'm going to work our way around the room, sir. I'm going to work our way around the room.
Well, because we're left-wingers. We get in first, you see.
I'll come to you. How's that? I'll come to you next, okay? I know. I will come to everybody, honestly. Where you go.
Thank you very much, Madam Chairman. I can just start by saying I completely agree with a colleague behind me. I've got proud to say a comrade behind me. Because the problem is underfunding, and I want to ask specifically the panel to comment on how great the underfunding is. In 1945, we had a Labour government that had a vision, and they took on a lot of special interests. And that special interest was not just the doctors, the consultants, but the hospitals. And they did something very brave. They nationalised the health service. They stopped people having to march up and down the streets, having parades to fund the cottage hospitals, like Brampton and Ulston. Right? Because they go on, that's the only way they can provide the cover. And now we're faced with the same underfunding. And the problem is, and it belongs to a succession of governments, not just the Tories, but the last Labour government, who underfunded the health service and allowed the cancer of privatisation to creep in slowly and insidiously, and it's now destroying us. And part of that is the PFI. Without any doubt, it's crucifying not just us, but other PFI funded hospitals throughout the country. And specifically, a question, and I've got a special interest in this. I was in A&E 4 weeks ago, and you start in A&E, you end up in the depths of the hospital, and you can't get back out, and you've only put £1 in your parking meter. And you come out and finally got a ticket offering you £70 for death by strangulation, or £40 if you want a quicker solution to it. You said that you've got to have a hospital in Carlisle fit for purpose to accommodate all this. A very simple question. Where are you going to put all the cars that are going to park, that are coming in from West Cumbria and Ulston and Brampton and the top of Ennerdale? Where are you going to put the cars? Because you can't, there's nowhere to put them now. Right?
Okay.
I'm specifically to that question. Why are we being charged? Why are we being charged to park our cars at a hospital? Right? Why? And why are the people who work there being charged to park their cars? It's immoral. It shouldn't happen. And I believe that a political party made a promise that they were going to stop the car parking charges. Well, I think they should. It's ridiculous. Because part of the
Can
PFI,
we move on, sir, please?
Certainly can. People are making money out of car parking. It's not going into the health service.
Okay, thank you. I mean, it was quite a lot of information there. Two questions, really. One was around, clearly, the underfunding, which, again, you know, I think you did talk about, you know, it's a national problem, but I do think it requires a response from the panel. And the second thing is clearly there is a new build programme with a transport, car parking. May we respond to those, please? And can I ask us all to please be more brief in our questions, because we are finishing at 8:30 and there's a lot of people want to ask questions. Thank you.
So if I pick up the statement and question around the funding, and then I'll hand over to colleagues from the Trust to pick up the burning issue on car parking. It's a really important point that the proposals that are being presented to you today and that we are consulting on are not finance related. There are significant financial issues in our health and social care system. The net effect of these proposals, should they be accepted, would be somewhere in the region of £2 million a year. But the backdrop is a health system that is overspending relative to its budgets to the tune of £70 million a year at the moment. So the changes that are being proposed, those options, are purely about safety and quality.
I'll pick up the question on car parking. We have made some changes already at Cumberland Infirmary site, and we have done those in conjunction with colleagues at Health Watch, who are, as you'll be aware, a patient panel group. They have reported back to us that the changes that we've made have been significantly well received by the general public, and they did that independently. And those visitors who come to our site now are finding it easier to park. In relation, because Health Watch have undertaken an independent survey and fed that back to us. We can ask. That's a Health Watch document.
Okay. Well, we've given them the chance to answer. We may not agree with all the answers, and we may want to challenge that, but we do need to allow others to answer questions.
And just for the future, we are working on an additional circa 240 car parking spaces on Carlisle site, and that should be available sometime in January.
Before the end of the consultation?
Because we have parking issues for staff currently, we want to free up further space. The car parking spaces are being built because we have insufficient space currently to accommodate our staff car parking, because we have moved around to accommodate patients better.
Okay, I'm going to move this topic on. I've got 4 people who've tirelessly had their hands up, and I'm going to work. So there's a lady here, there's a gentleman there, there's a woman in the back. This woman's had her hand up for a long time, and then we're going to come to the 3 over here. So we are coming to you. Can I ask you to make your questions brief, please?
Yes. I'm Alice Bondy. I have looked at the equality impact analysis that you have on your website, and to say I'm appalled is to be something of an understatement. You say very clearly that there's a lot of older carers, they're more likely to be men, and yet you say that there is no significant problem in terms of a differentiation between men and women on any of these issues. You also talk about the impact of rurality, but then fail to actually say anything about how you're going to mitigate that. You talk about perceived gaps in public transport. And I wonder if that means that we're all suffering from a collective illusion that there aren't any buses on Alston Moor. You know, I think my perception's fairly good. There are gaps in public transport. End of story. You claim that this is on page 33 of your equalities impact analysis. The proposals related to community hospitals are unlikely to impact specifically on either males or females. Well, having said that more women are carers, and having said that they're likely to be poorer, and having said that there's basically no public transport, does it not cross your minds that there are going to be more women having to try somehow or another to get themselves to Carlisle Hospital to visit people? That the impact on people who visit patients, whether they're coming from West Cumberland, from Alston Moor or anywhere else, seems to have been completely overlooked, apart from some completely absurd statements like it's important that any proposed changes to community hospital provision are mitigated through the timely provision of community-based services, that there is mitigation needed for emergency transport, emergency transfer, that there is mitigation through the timely provision of transport, etc., etc. I mean, this is just a load of cack, you know.
Okay. Really, really strong statements on equality impact assessments. I have to ask, what was the question?
The question is, if...
She asked the question at the beginning, I couldn't quite...
Yes, I want to understand. Okay, firstly, why is your equalities impact analysis so completely lacking in any connection to reality? It just seems to be a load of platitudes. And what are you going to do about the real issues in terms of equality, in terms of women who are far more the carers, especially in rural areas, not having any way of getting to see people? My real concern, I might say, in all of this is that women will try and keep the people for whom they care at home much longer if we haven't got Alston Hospital for them to go into, and then they will suffer health breakdowns. I want to know seriously how you propose to mitigate these things that you idly talk about mitigating, giving absolutely no detail, just like there's no detail about what these integrated care communities are.
Okay, we get it, we get it.
So thank you very much for sharing your views on the equality impact assessment. Now, the governing body of the clinical commissioning group will look very carefully at what the equality impact assessment's concluded, and where there are clearly risks and the need for, to quote you, mitigations, that will all be taken into consideration. Now, if they are not satisfied that the mitigations are appropriate to address any of the issues raised in the equality impact assessment, that will have a bearing on the governing body's decision as to whether they think the proposal can be supported. So thank you for raising your concerns. I'll hand over to Michael, because he does have perhaps some helpful advice as to what mitigations are being considered around transport.
Thank you. There are two things that I would say in response to the question. The first is that we're well aware that there will need to be improvements to transport to support people for visiting, and that's what we're planning to put together so that people can still visit where they want to. Also, we expect through these plans overall more people to be able to be treated closer to home. So actually, we feel that overall the amount of people travelling will be less. And then my second point is that we are actively working with partners and with organisations that support carers to try and make sure that whatever support carers require, we can try and respond to that in the best way possible, including visiting and travel where that's necessary.
Okay, we're going to move on. This lady in the back's waited a very long time in the black top. You still got a question? Can you just hang on for the microphone, please? Thank you. And then I'm going to come. Can I then come to this gentleman here and then across here and then this lady? Okay.
It's about choice again. There doesn't seem to be much choice. And are you consulting with patients sufficiently to meet their needs and their safety requirements? Because often they know best.
So the consultation is widespread, and women who will be having babies in the future are part of that consultation. It's been.
But have you had discussions? I know you have with your midwives, but have you had those with pregnant ladies? And have they got a choice? Have they got a say? Can they plan their own pregnancy? I certainly did. And I would like that choice. I wouldn't like to... In fact, I wanted a home birth and fought for that and had to go into the infirmary in Carlisle in a dirty bath in the end.
So absolutely, women are offered choice, and the national guidance that's recently come out around better births is how we plan and deliver our maternity care. It's part of the options that what we do every day. Women are offered choice, whether it's a home birth, whether it's in a midwifery-led unit or a consultant-led unit. Women are offered choice, and that's part of what we do now. I think it's really important to recognise that women and you've said this yourself, you know what you wanted. You knew that you wanted to have a home birth.
We're going to struggle because you've got no microphone. People can't hear what you're
So
saying.
I think what you're saying is, how do we make sure that everybody really have a choice when they're having a baby, is what you're saying. Yeah. Yeah.
Okay, so just for those of you who couldn't hear all of that, a lot of it is about consultation directly with the recipients of care, whether that be the patients or their wider families, and the assurance that that conversation's going on. Would you like to continue?
Just from the perspective of the consultation, which obviously the clinical commissioning group is responsible for overseeing, we are working really hard, not just to meet with the public in general, of which we've arranged 17 public meetings, but there have been, I think, over 50 meetings with interest groups and what we call deliberative events, so events with smaller groups of patients and members of the public to go into detail about the viability of these preferred options. So we are working... Yeah. Yeah. Well, I agree, and part of the planning for the consultation was to try and identify those groups that do find it hard to communicate and maybe aren't touched very often by services. So if there are groups that you think we haven't contacted yet, and there is still time, I'd be very happy to meet with you afterwards. Well, yes, we have been speaking to women, to pregnant women, to mothers, to try and understand their opinions, particularly on the West Coast. So yes, we have tried. If there's more we can do that you think, then we will do that.
Okay, I think we've given a response. If you need to have a conversation about additional matters, I'm going to move to this gentleman and we're going to move along those lines there, and to this lady as well. I won't forget you, sir. You've waited a long time. Thank you.
My name's Alan Marsden. I live on the East Fell side, not far from Alston. You've set the context of this meeting under the word overspend. It's all about overspending. Two facts, or two areas of fact. The Germans, the French, and the Dutch spend 11% of GDP on their health service. We spend 8.5%. I know those figures have altered slightly recently under the King's Fund because for some reason, they've introduced private health spending into the figures to make the situation look a bit better from the government's point of view. The other fact is that today we hear from NHS providers, which I think is the umbrella body of NHS trusts, that 3/4 of NHS fund bosses say that they do not have sufficient staff to function properly. So bearing in mind those two indications that it's not about an overspend, it is about an underfund. We are underfunded in relation to our European partners, and to my mind, the shortages of staff indicates underfunding. Now, against that background, is it not premature to close Alston and the other community hospitals?
So again, I'm sorry if it appears that we're repeating ourselves, and I absolutely hear and acknowledge the concerns in the room over the level of funding for NHS services, but you'll appreciate that we have a budget set at the beginning of a financial year, and we are obliged to try and keep our expenditure within that budget. That's why we talk about overspends. But critically, this consultation is not about the money. It's about service areas where we are struggling at the moment to provide safe, high-quality care to the people of West, North and East Cumbria. Now, we can talk all night about the money, but actually that's not probably going to help a number of the people in the room that want to hear about the potential service changes. So I have every sympathy. And of course, who in the NHS wouldn't welcome additional funding? But there's no sign of it coming. So we need to address the service weaknesses we have with the resources we've got. That's our responsibility.
Sorry, can I?
This gentleman's not finished his question. Okay, we'll come back to you at the end because we've given you an opportunity. Sorry.
Of the three-quarters of trust bosses who said that they couldn't function properly because of shortage of staff, were the North Cumbria trusts among the 73% of bosses who said that was the case?
I'll let my colleagues from the trust speak for themselves in a moment, but what I would say is that from what we understand to be the challenges around recruiting staff to services in the Partnership Trust and North Cumbria University Hospital, it's not about the amount of money that's available to pay for those staff. It's actually about a range of other factors that are making working in those trusts unattractive. It's not about the money. We'd be kidding ourselves. In fact, one of the reasons that the acute trust, the hospital trust, finds itself in financial difficulty, one of the reasons is that actually it's paying well over the odds for its workforce because it's having to engage expensive locums to cover vacancies where it isn't able to make permanent employment.
But if you close Alston and in 3 years' time we get a civilised government, Alston will be gone. So is it not premature to close Alston at this time?
Okay, keep on. Can we move? There's a lady, a gentleman. There's a lady in the black hair and a gentleman next to him. Can we go to those two people, please, next? Can we...
So you asked... Is that on? Yeah. You asked something specific that I can't answer, so I can't answer your question as to whether or not we contributed to that survey or not, so I'm sorry about that. But we could... But we could go away and ask that question for you. But it's a very specific question that you've asked, and as I stand here, I don't have the answer to that.
I can perhaps give a brief response on behalf of our trust. With regard to the specific survey, I wasn't the respondent to that from our trust, but I can say that our trust currently has got vacancies where we wouldn't like them. We are currently utilising locum doctors and agency staff. We don't like to do that. We'd rather have permanent workforce. Our staff feedback to us that some of the roles we try to recruit to time and time again are not doable roles, not sufficiently safe roles, and that's why we can't recruit to them. So we're very keen, without being premature, to make our services attractive to staff so that they will come and work here, will come and settle here, and be a long-term workforce for our services. So those are the themes we're trying to get over in trying to create the services for the future where our staff can work and thrive.
Okay, I'm going to move this on now. Can we come to this lady in the black jumper, then the gentleman next to her, and then this lady here, and then we'll take the next round of questions. And I can see you in the hat in the back, madam. I haven't forgotten you.
Thank you. My name is Hazel Graham. This is a consultation, and I just wanted to slightly disagree with the way that you're running it. You're encouraging us to ask questions, but actually the panel should be here to listen to statements as well as questions. And I think you've also tried to narrow the debate down a little bit, and I don't feel that anybody in the room should feel that we have to just respond to the actual options set out in the consultation. The majority of us here reject the entire consultation. We think it's flawed. And it would be good if that could go on record, please. The consultation paints a false picture of overspend, whereas it's actually under-resourced, and to improve the services in Cumbria, there needs to be extra resource brought in. It's not a true consultation, and even the consultation document admits that the consultation that we're having here tonight is secondary to financial considerations. It's sexist, as Alice mentioned. Women are disproportionately affected by the proposals, the closure of maternity care, the impact on carers. All proposals for maternity and children's services are completely unacceptable, and we reject every option that you put on the table about them. We reject the whole paper, and we demand that the proposals are withdrawn. We propose an independent community and worker-led audit into the NHS in Cumbria, so that the public, the BMA and health service unions actually feed into it. And finally, I do have some questions, and there's 3 of them. The first is, how do these proposals comply with equality legislation? The second is, all options are unsafe. Who takes responsibility when things go wrong? When someone dies on the way from West Cumbria to Carlisle, when someone dies on the way from Alston to Carlisle. And thirdly, given what you've heard tonight, will you agree to withdraw the entire consultation and start from scratch?
Okay, so there were 3 key questions there. The first one was around the equality legislation. Who'd like to respond to that first question, please? And then we'll move on to the options around safety, and then finally the withdrawal in terms of the process for the consultation.
Okay, I'll give 3 brief answers so that we can fit as many questions in as possible. We do believe we comply with equality legislation. We've taken legal advice, so that's our position. Responsibility rests with the provider organisation that claims to be providing safe services, and it will do all that it can, obviously, to ensure those services are safe. I must point out that one of the reasons we're consulting on these proposed changes is that there are real concerns about the safety of services as they stand. That's why we're here today talking about these proposed changes. And then thirdly, no, we're not going to withdraw the consultation and start from scratch. We want to see this process through. We want to receive the independent assessment, and then the governing body of the clinical commissioning group will make its decision in the spring.
Okay. Second question was the chap next to you. Thank you very much.
Thank you very much. I'm Mike Danham, retired consultant paediatrician. I want to bring to attention a group which is all very close to us, and that's children. And the extraordinary suggestion that withdrawing full acute paediatric services from West Cumberland Hospital can make any sense. Can I take you back for a moment historically to 50 years, to 1964, when the West Cumberland Hospital was built, the first new built hospital in the National Health Service. And shortly after that, a man called John Platt was appointed as consultant paediatrician to the hospital. Note that he was the only paediatrician in Cumbria at that time. There wasn't a paediatrician at Carlisle. And the fact that he was appointed at Whitehaven, not at Carlisle, reflected the new then and fundamental understanding that illnesses in children develop more rapidly and more unpredictably than they do in adults. And it was that understanding which was at the base of improvements over the last 50 years in children's services. And in relation to that, the extraordinary improvements in mortality and disability rates in children over those 50 years. What appears to be a minor illness in a child can progress in a matter of minutes or hours into a life-threatening condition. So I end up really with this statement, and I agree with my friend that these questions are a little bit artificial, but I'll ask a specific question. So my statement is that removing acute paediatric services from the West Cumberland Hospital, 40 miles from Carlisle, will take us backwards 50 years to a time when deaths and disabilities in children resulting from delayed treatment were at least twice what they are now, and that's a conservative estimate. And my question is, as I understand it, one of the tests of any change in an NHS service which I think statutorily is the responsibility of the NHS to prove, is that any change must be an improvement on services in terms of outcomes. So my question is, what is your evidence, or what is the success regime's evidence that closing acute paediatric services in West Cumberland Hospital will improve outcomes for young children?
Thank you.
Thank you very much. That's a very detailed question. You're absolutely right. The premise of the consultation has to look at and consider the risks now that we currently face with our current paediatric services, which are not insignificant given our real challenges with workforce, although we continue to work very hard to rectify that. And the balance of, should the change happen in the way that it has been proposed, the risks associated with that. So neither of the options, the do-nothing option and the option of transferring a small number of children, so the majority of children would still continue to have their full level of care at West Cumberland Hospital under this proposal, but a small number of children would receive their care in a centralised service. That, of course, would have to be robustly risk assessed and risks managed with our paediatricians, should that be the option that was selected.
The risk assessment should be before the decision. Do you not see that?
Okay, we're going to move on to this lady here, and then I'm going to the lady in the blonde and the gentleman in the blue jumper.
Thank you. This is about Alston. 2 weeks ago, myself and my colleague came over to the Success Regimes meeting, and 2 weeks ago we had to go through 5 or 6 foot of snow. Over those 2 weeks, in the road that we went across, there was 15 accidents. I'm actually getting the data from the police. But this is the road that you are really seriously suggesting that people from Alston go to what you call our natural community of 70,000 people. It is absolutely impossible in winter, and Cumbria has snow in winter. We're a bit renowned for it, and especially Alston, which is the highest point in the Pennine chain. We have a lot of snow in winter, but yet you expect us to go across to Penrith to get NHS services, and you equally expect NHS services to come across that same road that there were 15 accidents on in only a week. This is just absolute lunacy. My second point is that social care is in absolute disarray. It was being discussed in Parliament yesterday because it is in such a state. To suggest that integrated care communities, that the Health Board has got nothing, has no control over because it's social services and the voluntary agency, that this is going to be the solution, again, I think is absolute madness. It is already in complete disarray. And all I think that this success regime is doing is it's moving the risk. It's moving the risk to our community, because don't tell me we're going to get safe care trying to travel over that road in the snow, because we're not going to get safe care. Your hospitals might be able to provide safe care, but we won't be able to access it. And don't tell me we're going to get safe care in Alston, where there already isn't a voluntary sector to provide social care, and all of the staff already in Alston dealing with social care are run off their feet. It is absolutely madness.
I'm Jane Mays. I've come from Alston as well. And I work with the End-of-Life Care Research Group of the Free University of Brussels. So what happens in Alston Hospital is a particular interest of mine. But first I want to say, is it Dr. John Edred that I'm talking about? Who's something...
No, well, John Platt. It was Mike.
No, it's somebody more recently who's a retired obstetrician. Eldred, thank you. Who has produced a very well-resourced, well-referenced paper which shows that there will be double the deaths perinatal mortality if this plan goes through from West Cumbria, and has also worked out, in a referenced way, that the price that the success regime puts on a child's life, is a fraction of the price that NICE, the National Institute for Clinical Excellence, puts on a life, which is, I think he said, 380,000 to a higher figure. That's NICE. 140,000 is your figure. Now, yes, you need to read that. It's very well referenced. I was thinking and working about Alston when I read this, and I was utterly shocked. And I felt that, in a sense, what's happening out in the West, particularly with a view to the New Gen project, where there's supposed to be, some people say 21,000 new jobs, that's going to be young childbearing families. It seems to me to be unrealistic, so unrealistic to put this plan through now that it's almost laughable if it wasn't so serious, and it wasn't so serious in terms of increased perinatal mortality. But I need now to go to the other end of life, which is almost as important, and those of us who are approaching it think that it is as important. There's quite a few people here from Alston tonight. It wasn't that easy. We stood around in the car park absolutely freezing, and really thankful that it wasn't icy, and it probably will be when we get back there. If you close Alston Hospital, as is your plan, those people are going to have to come and die in the Cumberland Infirmary. That means urgent. They're not going to die in the nice end-of-life palliative care expert way which is offered in Alston Hospital. They're going to die in emergency care or in the high dependency unit, or with treatment that they haven't wanted, that their GP knows they don't want, maybe their family knows. And that is something which evidence shows reflects in increased mental and physical health, ill health in the bereaved. I've got a story that my friend, who's still suffering almost a year later, wants to make public, but she hasn't got the courage to do it herself. About her husband, they'd just suffered, really tragically, they'd just suffered another death in the family. He'd been a sick man for quite a long time, her husband, and he was taken to Cumberland Infirmary instead of Alston Hospital because the doctor suspected something that would need treatment in the infirmary. He was in there for 2 or 3 days. He was sent home. Oh, the bit that's talking about visiting, as people have been, she felt in January, after the floods, in the heavy, heavy rain, that she didn't have the courage to drive herself to the hospital. She couldn't go with him because she thought, how on earth am I ever going to get back? And she didn't have the courage to drive herself. After a couple of days, he was sent back in a taxi. In a taxi. This is a man who was dead within less than a week later. In a taxi with a stranger. And the stranger had to be dropped off at Acorn Bank. Now, anybody who's familiar with the geography, and particularly last January, will remember perhaps that the bridges were closed. Acorn Bank is the other side of the Eden, or they had to cross the Eden twice to get there. To get back to Alston, I don't know how they did it. They probably had to go completely back to the motorway, up to Carlisle, and back the normal way. As I said, this was a man who was dead within less than a week after that, sent home in a taxi with a stranger via the extra long route, not just the long route. Finally, what I want to say is that for the sake of some of my colleagues and friends I've known a long time, the success regime itself, what you're doing now, everything is justified by the fact that it's not working at the moment. It's very convenient that healthcare is underfunded at the moment. Healthcare is underfunded everywhere. I'm going to a conference in Brussels on Thursday, the 1st, is that Friday, called Healthcare Transformation Through Innovative Disruption. And this is a global program. It's not just a European program to transform healthcare through disruption, which is what this is. In order for the big companies, it used to be big pharma that was the enemy, now it's big data, to move in and introduce a revolutionary kind of healthcare, as we're warned in the STP, the Sustainability and Transformation Plan, which was published a week last Monday. We have to change our way of thinking. We're not going to receive healthcare in the way that we always have done. We're not going to receive what they call paternalistic healthcare. We're not going to receive wraparound healthcare. We're going to receive monitors, maybe for our organs. Big data is going to hold the answers. Big data has got massive databases. I work in data myself, so I know some of the values of this. And this is what the success regime is. It's the stormtroopers sent ahead to slash and burn, to cut services before the STP takes over, which is beginning now, friends and comrades. So let's be ready for the STP. Thank you.
Thank you. So we have a couple of gentlemen at the back. This chap at the back, he's raised the vat, and then this chap over here. And then I do need to come back over to this side. I'm conscious that I've had to keep my attention over here. Over to you, sir.
Good evening. I'm Barry Atkinson. I'm from Alston. Firstly, I'd just like to say to the paramedic, thank you, we've got our ambulance back. It's taken a hell of a long time, but we've got it back. And I'd also like to just mention that Carlisle has now restructured its N&E, which is health and whatever, someone help me, the emergency department that one goes to. And they've done it in such a way that I think most likely will work, and that was without you people, because I was told you had nothing to do with it. I'm not sure I believe that. On those points, they're good points, and I'm happy about that. You've really gone about it the wrong way. You've made a consultation document before you consulted, and the people don't suddenly read it and find they've lost the beds at Alston. You should be putting that back in as one of the offers. Even if you don't like it, it should be in there, because that's what was there before. And it's 7 beds at Alston. It was 12, but it's 7 now. If Alston loses its beds, it doesn't just lose its beds, it loses its nurses, because they'll close down the daily miners' injury unit. And what will happen then? It means that we'll lose our doctors. That's how serious it is up at Alston. We've already got 2 doctors that are departing, and one won't be far away. And we can get the people up there, and Carlisle can't get the people, because Carlisle's not like a lot of other hospitals. It's run very badly. It really needs to up itself. And and I'm not asking questions, so don't stop me yet. As far as Carlisle goes, it was opened by Tony Blair. It was a PFI. Why, I've no idea at all. It opened it in such a way that it has a massive entrance, a long entrance, no rooms. And it was all done wrong. And also, when they built it, there was 8 beds less than the original hospital. I mean, obviously, you want to go that way. The Labour Party brought the NHS in, and it was the best, or the only best thing that the Labour Party did, but they did bring that in for everybody. Now, you just have to look what's already happened. The dental practice. I bet if I look at the teeth of all the people in here, you'll see they've got bad ones, or a lot of them have. They can't afford the private. And not only can they not afford the private side, they can't afford to go. It costs 18, 20 quid or something to go to the dentist. You know, pensioners, never mind pensioners, normal people just can't afford this, so the teeth come last. Where does a lot of disease come from? Your teeth. It goes down your throat and causes all kinds of trouble. You really have gone around it the wrong way. And
thank you. Have you finished there? Because we need to give some other people a question time.
Sorry?
Have you finished now? We just
No,
want to move
I
on.
haven't finished. No.
Can I ask you to kind of come to a
The
conclusion,
Ulster
please?
people here most likely don't like me speaking up. But
No, it's
I'm
fine. But
speaking
can you
up.
come to a conclusion? That would be great.
Right. Well,
Thank you.
I'm not going to read this then. But I think you've really got it wrong. I've been to 6 meetings now. You're all different people each time. What's going on?
Okay, I'm going to move over to this side of the room now. Thank you for that. Thank you for waiting. There's a gentleman, there's a young woman in the white top, then there's a chap over here at the back, and then a gentleman in the blue. And then we're going to go over there, and then I'm going to come back, okay? Did you catch all that? Sorry. I actually don't know because I'm new to this. So. Can anybody answer that? Why does the panel change? Yeah.
Well, I recognise you, sir. So I've been at least to, I think, 8 of the public meetings so far. But we try and rotate across the senior officers of the provider organisations to ensure that we balance the interests, the anticipated interests of the group of public that we're meeting with the expertise of the colleagues from those organisations. So it is genuinely the panel changes in the interests of the community that we're trying to engage with.
I'm sorry, I'm not getting any of this.
It's really difficult if you've no microphone. People can't hear. And if you need to ask that question, we can come back. So in terms of the chairs are independent, and that's why they've changed. So I'm doing 3, and just other colleagues have done 3 each. Can I come to this young woman in the middle? Did you get the microphone? Yeah.
Yeah.
Thank you.
Hi, my name's Penelope Foster. I'm just a student just here at the university in physiotherapy. I also work at the Cumbria Infirmary as a physio assistant. Can I just ask to go back to that slide with the stroke, hyperstroke? Sorry, can you all hear me? Yeah, I just didn't really understand what you meant by hyperstroke services. I've worked on the stroke ward quite a few times, and they've just had a cut in the number of beds. And now you're saying, okay, so we're going to treat more people with less beds. And, physio and OTs and speech therapists is a huge part of looking after people who've had strokes. And they've just gotten rid of the room where we saw the rehab room. So you're not rehabbing stroke patients, which is the main way to treat them. So I don't see how, first of all, it's going to be a better service when you've just reduced it and you've reduced the number of beds. I also wanted to mention that, just cuts in general, when the NHS in 1948 had 480,000 beds. That was when there was about 30 million people in the UK. Now we've got about 160,000 beds, so we've got less beds, you're making them less all the time, and the population's increasing. I feel sorry for you all up there because you're being asked to do things which are impossible. You can't save this money, you just can't. Why can't you say no? Also, So my question is, one question is, don't you have the right to say no, to not impose these demands on us? Number 2 is the ambulance gentleman. You know perhaps that in order for to get good stroke, so for people to survive from stroke, to increase that chance, they have to get to the hospital within a certain time. Ideally, someone wants to be thrombolyzed within 2 hours of getting there. do you seriously think that with these roads that people have mentioned, and you're reducing the number of places that people can be seen for stroke, that they will be treated and get there in time? And
can we take your first question?
That's all. I just had those two questions.
That's fine. That's fine. Thank you. That's fine. So if we come to Emma's second, just in regard to that first question, does the NHS in its current form have the right to say no? How does this work? And then secondly, can we then come to the question around the North West Ambulance Service?
The NHS, as I mentioned a little bit earlier, is obliged to provide safe, high-quality services within the resources that it's allocated. Now, this consultation, just to repeat, it is not about the money. It is about changing services, potentially, to try and address these safety and quality issues. So, the governing body of the Clinical Commissioning Group will take a view on all of these preferred options, and it's not impossible that it may disagree with all of them. So in that respect, the NHS can say no to the proposed changes. But I'll repeat, this is not about the money, and it's not the NHS saying no to the resources that it's currently being given to provide services. To answer your question, sir, about whether we're going to say no to the changes tonight, no, because that would be a breach of the consultation. We need to hear everyone's views, and not everyone shares the same view as you, sir. Not everyone shares the same view as you, sir. So we need to hear everyone, and we need to see the consultation through and receive the independent assessment, and then we'll take a view as to whether the CCG supports the recommendations.
Okay, we're going to move this question on to the second respondent, which is around North West Ambulance Service, please.
Yeah, in terms of stroke, you're quite right that we have timescales to treat stroke in the same way that we do actually for heart attacks, so people who have heart attacks, or people who are suffering from major trauma. And already we take patients who are suffering major trauma and heart attacks within quite well-defined categories into Carlisle rather than out west. And if there was a change that all hyperacute strokes would come to Carlisle, then we would endeavour to do that in the same way that we do very successfully with stroke, along with heart attacks and with major trauma. Of course, at the moment, we're not set up for that as such, and if there is any change in services, NWAS would continue to have dialogue with other providers, along with the commissioners, and look how that provision was provided in terms of ambulance numbers.
Okay, can we go to the gentleman at the back, please, in the blue jumper, and then this chap over with the spectacles on? I need to go to people who've not asked the question. Okay.
Hi, my name is Michael Oliver. I work for North West Ambulance Service, and I'm also a trade union representative for Unison. I've got a direct question, but I just have to disagree with the gentleman from the CCG when he says it's not about money. You've already said that there's an overspend of £70 million, and then it'll go up to 160 million if you do nothing. So it is about money, definitely about money. So my question is more about the concern about ambulance transfers. The BBC tomorrow will be reporting on our local radio stations that since 2012, we used to 350 transfers that the ambulance service did from West Cumbria to the Cumberland Infirmary. In 2015, that rose to 1,682. That's a huge amount of actual transfers that we're actually doing. As part of the success regimes consultation and one of the preferred options, you've already stated that if the option is to reduce the services at Whitehaven Hospital, you will put in place a dedicated ambulance vehicle of which you will fund. But my question really is that it's not just about the dedicated ambulance, it's about the additional transfers that we will be doing in relation to stroke patients, to paediatrics and to maternity. So what assurance can you give that the ambulance service will be properly funded so that patients aren't compromised?
Mike, as you know, that as I've just said, we are currently funded, and the ambulances are the numbers are designed around the current configuration. So with any changes, we would go back to the commissioners, and we would look at the numbers of transfers expected and adjust accordingly. That's the bottom line, really. In terms of the dedicated ambulance vehicle, I'd just like to say that is one of the options that's being looked at. And along with everything else that hasn't been decided on yet, we are looking into that within NWAS, as you know. And one of our colleagues, Rick Shaw, went down to a similar scheme down in Pembrokeshire. It's a similar scheme. They have a dedicated ambulance vehicle there, particularly for the maternity transfers. But that is there are different challenges down there. There are better roads, shorter distances. So we've taken some lessons from that. We're looking at that model, but it is only one of the options. So it hasn't been decided on yet.
Okay. There is some people there at the back. This lady in the black, if you don't mind. And sorry, it's the chap there in the blue, and then yourself. Sorry, I knew I'd missed you.
Thank you. I'm David Niven. I'm an NHS service user from Carlisle. I'd just like to pick up the point that was made earlier about the lack of firewalls at the PFI Cumberland Infirmary, because I think it's an important point, particularly when some of your proposals are going to mean, if they're pushed through, are going to mean services coming from other parts of North Cumbria, North and West Cumbria to Carlisle. First of all, does the top table accept that the PFI contractor built the hospital without putting in the requisite firewalls? And two, what plans are there to rectify that work? Is it going to mean patients having to be moved out of wards while the necessary work is done? I think we need answers to those important questions, and who's going to pick up the bill. Another point is, I think it's heartening tonight to see the level of solidarity across Cumbria against these cuts, and that we're not just here to defend services in our local towns or cities, but we're all going to support keeping the beds at Alston and Wigton. We're all going to support keeping the services at West Cumbria, and also defending our services in Carlisle. So I think that's a heartening thing. And also, so many people who've made contributions tonight have said that we can't support any of these proposals for cutting our services. I would support the call for a vote at the end of the meeting tonight as to whether we reject all of the proposals for cuts to our local services.
Okay, so can we talk about PFI? So the first question that you asked there was in relation to PFI. What plans were there around rectifying it? And finally, it was a bit around response to cuts. So we'll come to those three, sir, yeah?
Thank you. I think it's probably now a matter of record that there are some issues, some significant issues, that were highlighted by ourselves as an organisation when we re-inspected the building at Cumberland Infirmary. We have put interim measures in place to make sure that our clinical services across that hospital are safely managed. We started initially as our interim measure, which was to work through our alarm systems and make sure that they were absolutely fit for purpose for the 21st century. We have done the work on the fire alarm systems. We do have fire wardens in place, you're absolutely right, and we have fire responders, and we have undertaken a significant programme of training with all of our staff on site around fire safety, as all hospitals should. At the moment, we are now working on what the full-time solution, the longer-term solution needs to be for that. There will be a significant amount of work that would need to be undertaken at Cumberland Infirmary, and we are planning that with our provider organisation now. We are doing that absolutely in conjunction with our local fire services, and they have helped and supported us every step of the way to understand what we need to do in the longer term. The work is underway through discussions contractually as to where the remit for payment will lie.
In other words, we're going to pay again. We're going to pay again, aren't we?
So we are...
taking the money and run to the Cayman Islands or wherever it is.
We're under discussion contractually about that currently. But what I can say is there is a plan now that will, over the course of a number of months and longer, rectify the work, that put in those rectifications that need to be undertaken.
Okay.
Into a hospital where there aren't any firewalls, where you're having to do remedial work, closing wards down so that they can have firewalls fitted. How can you carry on with this when it's going to take 5 years to do?
Okay, I'm going to move to the lady at the back, please. Then there's a gentleman over here, and then I'd like to come to the gentleman in the front, and then the lady in the blue. Okay, sorry to have kept you so long.
Thank you. My name's Kay McGregor. I'm the operations manager at Carlisle Carers. I just want to say that at the moment we are experiencing a large amount of the phone calls from carers who are already experiencing the extra burden that is being put on them. We're having people phoning us and saying, we're at the end of our tether, we can't do this anymore. We work with young children from the age of 7 up to those people who are in the 90s who are carers. It's extremely concerning to us that I've actually attended quite a few of the success regime meetings, and if you read the document, it's very little about carers. There's very little about any of them in there. And I think, from my concern, I think they're a free resource. You should actually be respecting them because they're saving you thousands and, millions of pounds in actual fact. I can't represent them here this evening. I doubt there's very many of them here because they actually can't get away from those very strong caring roles that they have. So I'm probably not doing them justice. But what I'd like to ask is, has there actually been any risk assessments done about the burden that's going to go on to our unpaid carers?
Thank you. I think the point you raise is very well made, and we've certainly identified that we need to do more work with carers and organisations that support carers. It's something we've started, but we've got a long way to go at. So I think at this point in time, it's something that I'd certainly welcome engaging with your own organisation on and others like yours. Thank you. We're very pleased to make that contact and follow that up, certainly.
Okay, we're going to move to the gentleman over on the left, please.
Thank you. I'm Graham Higginson. I live in Carlisle. I was at the first session in Carlisle some weeks ago, which wasn't very well attended, and I'm very glad to see that there are a lot of people here to listen to the presentation and, more importantly, to give their views, because that's what you need. You need views from the public. Having heard the presentation again, although by a different presenter, it's the same old story. And I'm no more convinced this time round than I was last that, you're really here to listen to anybody. I believe you've had, was it 17 of these sessions all around the county, and they've been very well reported in the press, and it seems that nowhere in the county have you been able to persuade anybody that withdrawing services and transferring services and downgrading this, that and the other is going to improve anything for anybody except the people that make money out of the NHS. And one might ask, what's the point of this consultation? Well, consultation, to my mind, seems to have become these days a con of the public to persuade them that you're listening to their views, and an insult to the public because you present them with alternatives, none of which provide better services, all of which generally provide worse services in terms of convenience to the public, safety, and all sorts of other things, has been pointed out over and over again here. So I've got two questions. One of them's for you. How do you think you can get away with this? And the other one is to the people here. What are we going to do about it? You know, yes, I think we should have a resolution at the end of this meeting to say that we reject it. And we ought also to make plans to join with other people in other areas, not just in Cumbria, but all over the country who are facing similar problems. And it's not all down to PFI, that is part of the problem here, but there's a general attack on the standards of the NHS and the purposes of the NHS. And we don't just want to throw a bit more money at it, which will go to privatised companies. We want to restore the proper, free, universal, unbureaucratic, non-privatised basis that the NHS had in the first place. So, so my question to the public here is, what are we going to do about it?
Okay, so there's a couple.
On behalf of the public, just to briefly respond to Graham's question about what are we going to do about it. Sorry.
Can I just, ladies and gentlemen, can we try and depersonalise this a little? Yeah. There's more than 4 people in the NHS who run the NHS. Can we just have a little bit of order on that point? We need to move on to the questions.
Yeah, that's fine. I'm going to respond to the second question. Just to make sure that we can all keep in touch after tonight's meeting, there's 2 main ways that I know of to do that. Firstly, there's a Facebook group called Save Cumbria's NHS, so it doesn't have to end here tonight. If we don't get the response we want, we can all join that Facebook group if you're on Facebook. If not, the News and Star will be keeping people up to date with meetings that are going on. So that's, I guess, the first key thing. Let's make sure we don't all lose touch with each other. I just wanted to recommend that.
Okay, well, that's really helpful. I'm glad you've said that. I'm coming to you. I want to go to this gentleman here, the girl in the blue, and then you in the green. Okay, because I keep having to come back. Can I ask you to keep it somewhat brief? I'm conscious of the time, folks. It's 8:15.
Yeah, my name's Dave Neggs. I'm from Penrith, and a lot of the points that I keep about to make get made. So, but I mean, firstly, I'd urge the panel to join that Facebook group as well, because there's lots of you will hear what people have got to say. I get a feeling that the panel aren't here to listen to what people have said. We started with this thing about nothing is predetermined, but we already know that the options are predetermined. How many people here want a 4th option of no action, maintain the status quo? We're not being given that option. I'm going to be the 3rd person tonight in about the last 10 minutes to call for a vote so that you know exactly the strength of the feeling here for no action, reject this consultation and start all over again. So what I want to do now is to ask everybody to vote. Everybody who wants to vote for no action and reject the consultation, please show your hands now. So that is rejecting every option in the consultation. Thank you. I don't want anybody to feel intimidated. I think that was an overwhelming...
Can I please just temper this with 2 things? That there are also ways for you to register your dissatisfaction and disagreement. There's a consultation. I understand that, but I do understand how the NHS works. I haven't worked in it myself. I would seriously urge you to do 2 things. The lady, I'm sorry, I don't know your name, but clearly there's a lot of support for local people to have a local voice and be part of that. It is really important. The second thing is, please use that consultation document to register your dissatisfaction or disagreement. I don't think... I have to... Whilst... Sorry, sir, can I finish? Whilst whilst I recognise the enormous dissatisfaction this evening, I think colleagues will take that away tonight, but that will not stop this consultation. You need to use those documents as well. And I'm going to move us on in a question because we've 10 minutes left. Thank you, honestly, for that. I do appreciate it.
Can this be fed back to the local press, that was the outcome of this meeting?
Absolutely. I think we've got a comms person here this evening. Can I move to the... And I think that's... Yeah. Can I urge you to do two things? I don't work in the NHS, sorry. I'm trying to give everybody an opportunity. Okay. No, I understand that. I do understand it, but I am trying to give everybody a chance to have a say. Can we move to the question, the lady in the blue, please, for that question? And then we're going to finish off with the gentleman at the back, because we will have hit the time then.
Hiya, I'm Helen Davison. I used to work as a public health doctor in Carlisle and North Cumbria. There's several things that have been raised today that leave me really quite concerned. Firstly, there's some clear evidence that is being sort of shown around the room. Rebecca over there spoke about stuff. There's other sort of doctors around have shown some quite serious issues around safety. And when the question went to the panel, the answer was not that, yes, we're going to look at that evidence and maybe we need to reject the consultation option as a process, but rather it was, well, we want to keep the consultation option that we've got, but we're just going to look and see what we can do about that by making services better. But I think if it's shown that the issue is about safety, if the issue is about the safety of people travelling up and down the A595 with women in labour, children who are seriously ill, and there's good evidence out there, I'd very much like that the people who are looking at this consultation in the CCG look at the evidence and take all of the evidence from the work that is being done within the community and really look at it seriously. There's a lot of stuff on the West Cumberland Hospital, Save West Cumberland Hospital Facebook page. I've seen a lot of stuff on there from past doctors and other people who are concerned, and I'd really like that the consultation's taking that into process. There's a couple of questions that I feel that ought to be able to be asked by the CCG and those looking at it. And if you cannot answer yes to these questions when you're doing your analysis, I think that you should be rejecting all of the options that are being put forward. Firstly, is making these changes actually going to improve safety for all patients? Is this going to improve safety of care for women in labour and for children being transferred to other hospitals and for people having strokes and for people living in rural communities? I'd also ask that, given that we have considerable issues around health inequalities in Cumbria, where sort of most deprived areas, people in more lower socioeconomic areas, it was often in West Cumbria, have poorer health, is taking away services from their hospital actually going to improve their quality of their care and improve their ability to actually access care? I'm concerned too about the transport issue. The public transport in this county is absolutely appalling. Cuts are being made at government levels, taking away public transport, and I'm wondering how, when it's suggested that transport issues are going to be sorted out, whether the NHS can also sort out the major public transport issues to enable people to get from West Cumbria, from Alston, from our peripheral communities, to the hospital services that they require. So, overall, I am pleased to hear that you've said that you are willing to say no to all of the options. I'm wondering if, as a panel, you've got a plan, if you say no to it, or if it's very much hoped that you're actually going to go through with one of those options. But I would say that coming back to the ideas about the Facebook groups and the communication here, there's a lot of communication going on in this local community about people who want to save the NHS. And I'd like to suggest that any further plans that come out, if the consultation comes to say no, actually properly consults the public, actually engages those of us who are involved in services at a wide level, people who are involved in this room, who are the sort of carers, people, everyone who is expressed an interest here in wanting to make better. I don't think that saying no to this is about doing nothing. There's clearly need for reform of our health service, but none of these options that you've put on the table today are options that we're wanting as a public. I think there's potentially better ways of delivering healthcare services that do not involve these cuts. I'm aware that Dr. Mike Downham has put a very interesting paper together about just reconfiguring how we do healthcare more generally, looking at it much more widely. And so I'd like you to look at all of the local experts in our community and ask us what we think, as opposed to doing this paper exercise that, as it appears to be.
Thank you very much, and thank you for waiting.
Just on that, I'm certainly, I'm sure I can speak for the whole of the panel, very willing to consider all of those pieces of evidence, and if we can be provided them, I'm sure many of you have already provided them, then yes, they will be taken into account in what we consider as your feedback.
Okay, there's two more. We're going to visit this chap at the back and the man at the front, and then we are going to need to close the session. Sir, can I come to you first, and then I'm going to come to you.
I don't know if it's working, is it? My name's Craig Johnson. I'm an NHS user in Carlisle as well, and I'm more concerned now than I was at the beginning of the meeting, because we had a number of assurances given to us, first of all about the maternity care services in West Cumbria that haven't satisfied any of the questions that I've got regarding the reliability and the robustness of those services if you actually take those away from West Cumbria. And I, as someone in Carlisle, stand shoulder to shoulder with people in West Cumbria to defend those services that they've got in that area. The other thing I wanted to say was about the issue about the strokes. There were some very specific questions asked about transportation, and we were told that these were things that were going to have to be looked at if the proposals went forward. But there's no answers to where they are now, and we're already in the consultation. And the other question that was asked and was not answered was the one about transport if you close these cottage hospitals down. There is no answer at all about where you're going to put these people and what provision is going to be made for them in terms of alternative transport. You're going to look at innovative solutions. Well, what does that mean in reality when you're trying to get through the snow from Alston? Does it mean you're going to be providing these elderly people with a pair of skis? I mean, that's the reality of the situation. And we've also heard from Carlisle carers about the pressure they're under. And we hear that you're going to talk to volunteers and you're going to talk to your partners. We know the county council is reducing its provision of care services in the county and changing how it does things. Who are these mysterious people that you're talking to that's going to pick up all these different services that you intend to cut? Now, I accept that you have a clinical problem in terms of the number of locums and agency staff that you've got in the NHS in Cumbria. You have a staffing problem, there's no doubt about that. I don't believe that the answer to that staffing problem is to cut the services that we've got. You should be dealing with the staffing problem that we've got.
I think just take your points there. I do think there hasn't perhaps been enough responses around transport. I'm going to ask the panel to respond to that first. So can I come over to you and then we can come back to the other points, please?
Clearly, there is a need for these options to have a very full analysis around the travel impact and the solutions If we haven't got that in the consultation document, which isn't there yet, then clearly in bringing together the proposals, considering whether they can be implemented, any final decisions, that will be something that have to be pulled together. So that's a very strong takeaway message from tonight, and certainly we'll be able to take that away and do that work. Some of it's already in train, but we can add to it with some of the themes that have been mentioned tonight as well.
I think the other question was around your wider stakeholder groups in terms of listening and responding. I think somebody else asked that earlier. I think it was somebody over here actually around who are those people, particularly about how are you talking to patients.
County Council is restructuring its services, and it's going to mean less beds in the community for elderly care. We know that that's going to happen, although it may be more specialist. What we also know is that the people who are carers at home are struggling to provide the levels of care now. Those were the issues that have been raised from various different parts of the county. That needs to be addressed before you can go ahead with any cuts.
So you are absolutely right. No changes, if they are supported, could be implemented until the alternative services are in place. So you take the integrated care communities, we have to be satisfied that they are able to cope with any additional demand that the rationalisation of community hospital beds might present. So you are right. If the changes are supported, they will not be implemented until we have the safe alternatives in place.
Okay, and we're going to take our final question from this gentleman in the front.
Gareth Presh, I just wanted to ask the question, why is there such an overspend in the health service in Cumbria? And I'd also like to ask, why is there no consultant obstetrician here this evening? To have their opinion, they're the staff who are going to have to deal with these maternity issues. Also around patient engagement and involvement, surely there should be a member of the public on the panel with yourself who are part of the consultation so that they can give their opinion. They're just some of the questions that I have.
Okay, so the first one was around an overspend in Cumbria. The second one's around representation. And I don't know if there's been earlier consultant of
Sorry,
obstetricians.
just one last question. Apologies.
It's all right.
Just to the panel, the proposed changes, in your experience, are they safe? Because you guys, you have plenty of experience between yourselves. Do you believe that these proposed changes are actually safe?
So Gareth, forgive me if I don't get these all. So in terms of consultant obstetricians, we have had quite a number of the public consultation and engagement sessions, consultant obstetricians, but we haven't been able to have somebody at every single one of the panels. But they have been working very closely with us all on that throughout the time. So the consultant obstetricians working alongside the Royal College of Obstetricians and Gynecologists have said, and it's contained within the discussion and the information that's on the website. So the Royal College of Obstetricians advised us that the preference, and I don't think any of the panel would argue with that preference, would be that if we could safely manage it for the future and have it sustainable, then we should continue to operate consultant-led services on both of our hospital sites. However, they also were very clear that if through all endeavours we were unable to show that we could safely and sustainably staff those services moving forward, that it was beholden on us to consider other options. And that's what's available through the consultation. So the consultant body, the midwives, and the Royal Colleges have all been involved in that. So there is a balance of risk, of course, Gareth, as you will know. So health services are risky things, and we'll have to balance that out, as I think I said earlier. Yeah, so if the consultant obstetricians were here, they would say that the option that is the preferred option is a safe and viable option. With some work and caveats that would be needed around transport, around identification early in a woman's labour of whether a lady needed to be transferred or not.
Okay. I think we need to bring. We do. I'm absolutely right. Yeah, and that's where I want to come back. There's two questions unanswered. One was around an overspend in Cumbria, and the last one was around patient engagement or a patient representative on the panel. And we are going to finish with those two questions. And overall, does the panel feel the proposals for change are safe? They're the last three questions, so I would ask us if we could be expedient in responding to those, because we are losing people.
Let me pick up the question about whether we think the proposals are safe. The reality is the services as they currently stand are not safe. We know that because the Care Quality Commission tell us that much. They're the regulators that come out and assess the quality of services. They tell us that these services are not fit. They are not reaching the standard required. And that's why, in the case of North Cumbria University Hospitals, it finds itself in special measures for 3.5 years. That in itself makes it even harder to recruit clinicians because they don't want to have a trust that's in special measures on their CV. So the question is not, are the proposals absolutely safe? It's the balance of risk between the services that we currently provide that are not safe enough and those that we are putting before you today as part of the consultation. In terms of the overspend, there are a number of reasons why our health economy is so stretched financially. And a contributing factor is the cost of a workforce that is reliant on locums. Locums are a lot more expensive than appointed staff. And that is a real problem that we face. And it's a bit of a catch-22 situation. Special measures, difficult to recruit, locums, costing us a lot more money, overspending budget.
And the final question was around a public representative on the panel. I don't know whether that's occurred in the previous meetings, what the plans are or how it's being managed.
Okay, so it's really important that the public and patients have their view. It's not deemed appropriate for them to be presenting the actual proposals, but I guess you can hear today what the view of patients and the public are, and we're constantly taking those throughout the consultation period. But no, we've not had members of the public on the panel. On occasions, members of the public have given their views, for example, Health Watch, on the proposals because they've been working with us on them. Some of the groups that are working on alternative proposals for community hospitals in Alston, Wigton and Maryport in those communities have stood up and said their piece about their emerging alternative proposals, which will be taken very, very seriously by the Clinical Commissioning Group.
Okay, ladies and gentlemen, I'm going to bring this evening's meeting to a close. Thank you for your patience. I know a lot of you had to wait a long time for a question. I'm sure that as this consultation continues, you would like to keep your own conversations going. Clearly, there's a Facebook going on. There's a consultation document. There's a consultation document in the other room. I would urge you to complete that because that will be formally analysed. And can I wish you a safe journey home and thank you for your time and patience. The consultation, as I understand it, is going to be analysed early in the new year. Can colleagues just quickly, can we come to you with that so you can put it on your Facebook as well?